So we've talked about the oral glucose tolerance test, the fasting glucose test, and the rapid. And then I want to talk about one more way of diagnosing type 2 diabetes, which is often discussed and these days also quite accurate. The advantage of it's called the A1C or HbA1c. The advantage of this particular assay is it doesn't require fasting, and so the blood is taken from the arm, and typically A1C levels measured. If it's below 42 millimolars, or 6%, you have normal levels. No further testing. If it's above 6, if it's below, if it's between 42 and 48, you have what are called pre-diabetic hyperglycemia levels, and you follow that up with then an OGTT to see how the patient responds to changes in glucose. And then anything above 6.5% or 48 millimolar, you probably have diabetes, and it needs to be confirmed, obviously, with some of the other tests that I mentioned to you. But again, the advantage of this particular test is it doesn't require fasting. So the criteria for the diagnosis of diabetes, first do that fasting. You can do the fasting glucose levels. Fasting, with the fasting defined as no caloric intake for at least 8 hours. So typically you do the test in the morning and you have the patient go all night without drinking or eating. Then you have got the OGTT, where you give them a sweet drink and then test glucose levels after 2 hours. Or you can give you can test for the A1C levels, as we mentioned. Again, the advantage is the patient doesn't have to fast. And obviously, in a case where the patient is having obvious symptoms of type 2 diabetes, in this case, the random plasma glucose test is probably sufficient. So this is sort of the typical order of tests that are used to measure and diagnose type 2 diabetes. So what about some complications? What happens to these patients, and what starts to become more and more of an issue, and why does it cost so much to treat these patients? Well, the most common cause of blindness in people of working age is actually due to retinopathy, and it is a common chronic complication of type 2 diabetes. In addition, you have a 2 to 3-fold increase in coronary heart disease and stroke due to macrovascular disease. Secondly, you have an increase in nephropathy, with 20 to 40% of all new patients needing a renal replacement therapy that have diabetes. Oftentimes, you get erectile dysfunction, and this affects up to 50% of men with long-standing diabetes. And eventually, in prolonged cases, you start to develop foot problems, with 15% of people with diabetes developing foot ulcers, and in some cases, 5 to 15% of those needing amputations, which obviously is a quite serious and dramatic event and life-altering. So what about this diabetic retinopathy? What does that look like, and how can it be identified? This is one of the things that, when you go in for an eye check, one of the things that they start looking for just to make sure. This on the left is what a normal scan looks like. I believe it's called an OCT scan. And then if you start to develop retinopathy, you'll have occasional microaneurysms and dot hemorrhages. So it starts to look a little darker and start to see small little light spots within. And then on the right here, showing the serious diabetic retinopathy with very irregular venous patterns. You start to get blotty hemorrhages, cotton wool spots, these little white spots throughout that are the telltale signs for the doctor to identify a patient who's starting to develop serious retinopathy related to their diabetes. So what are the stages of diabetic nephropathy? First, you get you start to develop albuminuria. So you start to get the normal levels below 20 mg per day, and then as it persists, you're going to start to increase all the way up to 300 mg per day, and in severe cases, up to 15 grams per day, which will then lead to serious renal impairment, obviously. Your creatinine levels will start to go up. Your blood pressure is going to go up tremendously as it goes forward. And you'll start to have signs of edema as your protein levels go up, and now your albumin levels go through the roof and your blood pressure goes up. So when you start to get renal impairment is obviously when surgery is discussed, but these small increases need to be addressed as fast as possible. And certainly when the patient starts to see edema or very high blood pressure, then it becomes a problem, right? What about these foot ulcers or peripheral neuropathy? So first types of things a patient will start to notice are loss of pain sensations. They might injure themselves and be unaware of it. Then they'll start to see motor neuropathy, so they'll start to see raised or arched toes, pressure points, callus formation, and even hemorrhage. And again, that they will start to recognize. And a patient and a doctor can start to recognize. When you start to develop, you can also get autonomic neuropathy where you get reduced sweating, dry and cracked skin, and then obviously this becomes a serious point of potential for infection because the skin is basically open all the time. And then gradually you can start to see also peripheral vascular disease where you see reduced blood flow to the feet. And part of this is that previous comment about the edema and the change in blood pressure. And this then leads to poor oxygen supply, which then exacerbates. Imagine you've got cracked feet, you get an infection, you've got poor oxygen, poor blood flow. The infection becomes worse because you can't deliver your immune cells to the infection. And obviously, that's a bad situation, and obviously these are some of the dramatic pictures that can be caused by this lack of blood flow to the foot. So, what are some other side effects that we talked about? Well, erectile dysfunction in men is a quite prominent one. prevalence increases with age, with 60% of men over the age of 60 with diabetes having erectile dysfunction. And this mainly comes from that autonomic neuropathy. Essentially, your nerves are not working nearly as well, and your blood flow is not working near as well. So the combination for function is a serious issue. Now, again, what are ways to try and reduce and treat such peripheral nervous issues? You try to improve the glycemic control, certainly reduce alcohol intake, substitute drugs that may impair erection. If the patient's in treatment, some of the side effects are obviously from the drugs, not just the diabetes. And a first-line drug treatment, phosphodiesterase type 5 inhibitors, 50 to 60% effective for treating, but can cause a severe acute hypertension. And obviously there's a variety of other approaches that can be used, including prostaglandin injections and vacuum devices to help the patient. So what about this macrovascular disease? This is, again, one of the other major financial burdens to the healthcare system, and that is that diabetes confers 2 to 4-fold increase in heart attacks, myocardial infarction, and stroke in men, and a 10-fold increased risk in postmenopausal women. Cardiovascular diseases account for 60 to 70% of all deaths in people with diabetes, and atheroma develops earlier, faster, and is more extensive in people with diabetes. So, with all these complications, what are some of the ways that type 2 diabetes can be prevented? We'll talk again about the drugs in the next series of lectures, but today we'll just talk about lifestyle interventions because those are probably the easiest and most effective, certainly in the early stages, but even also in the later stages. So reduce intake of refined sugars, reduce fat intake, reduce salt intake, increase exercise, and just basically having a more balanced diet. So 30 minutes of exercise a day can reduce your risk of developing type 2 diabetes by 40%. So instead of sitting here in a computer lecturing to you, I should be in Nanchang walking across that great campus, right? Exercising. I love the university campus, so big. Walking between lecture theater and the medical school. So diet is a big one. Obviously, people selling you food in the restaurants, they want you to, they treat it almost like a drug, right? They throw those very juicy delicious dishes in front of you, and to try and entice you to buy more food. And obviously, if you're not doing exercise appropriately, right, then it becomes an issue. So obviously, if you're exercising like these guys, it's obviously not going to achieve the effect that we need to reduce overall weight. So we need a balanced diet where we're looking at 30% fruits and vegetables, much less meat and fish alternatives. We need some smaller percentage of dairy, and then 30% of bread, cereals, and potatoes. And we need less than 10% containing sugar, which is the hardest part in today's diet, especially in urban settings. My grandmother lived in the countryside, not in a city, and she grew all her fruits and vegetables, and she lived until she was 98. And so there must be the science behind it must be solid, right? And I'm sure you also have grandparents that are similar. And this is the challenge, is that fat and sugar make up a tremendous amount of our diet these days, and it's just very difficult to avoid. So what are the daily calorie recommendations? I mean, this is basic biochemistry or math, that essentially if you take in too much and you're not burning it off, you will start to pile it on. So for men, we only need 2,500 calories per day, and for women, less than 2,000. And that is going to lead you quite satisfied, even at 1,000 calories. And after that, you start to get over the top, and that's the issue. And all it takes is, one hamburger or one chicken burger, and you've already blown up that limit. So what are the ways that we can try to reduce and prevent type 2 diabetes? Well, as I mentioned, it's just not that difficult. And the key is to try and identify very early on when these levels start to increase, and to then drive down that A1C, those A1C levels. So every 1% reduction in A1C levels leads to a 20% reduction in diabetes-related deaths, 14% reduction in heart attacks, 40% reduction in microvascular complications, and a 40% reduction in those peripheral vascular disease complications that I talked about. So it doesn't take that much to really make a difference. This is just showing you as your A1C levels go up, you start to see adjusted incidence for in complications. So every point that comes down, you see significant reduction in all of these values and all of these risk factors. So the key is to delay and slow down diabetic complications by tight control of the diabetes and of the hypertension, as well as reducing other risk factors. Smoking is obviously a major one that I didn't talk about, but is still, unfortunately, a major problem in the world, and is obviously adds to additional complications for diabetics. And obviously, the fat buildup is a major problem for on the vascular side of things. So anything to reduce that fat, and obviously to quit smoking, is a major one. So typically the doctor will start with lifestyle modifications, and then screening for additional complications, looking for those eye complications, checking blood pressure, and then keeping a monitor on the A1C levels. But the goals for the individual must be tailored to each patient. So first, we'll start with lifestyle modification before pharmacological intervention. You don't want to just start putting drugs into the patients. First, you want to try and get it so they can understand what their lifestyle is and how their lifestyle is contributing to their type 2 diabetes. And typically, this is going to revolve around diet and weight reduction and increased exercise. And following, if the patient doesn't respond, okay, and you're monitoring A1C levels and you're monitoring their glucose levels, and you start to see that nothing is helping, or they need motivation, then you will start to talk about and discuss the pharmacological intervention side of things. So all of these that we'll talk about, but the hope of these pharmacological interventions is to reduce the insulin resistance, increase insulin production by those beta cells, and by if there's still some around, assuming they haven't all been exhausted, and then eventually, if need be, provide insulin replacement. So we've talked about we've defined and talked about the etiology and pathophysiology of type 2 diabetes. We've talked about the symptoms of type 2 diabetes, and we've talked about how to diagnose it, right? We gave 4 different tests about how we diagnose it. And then we talked about the complications and why type 2 diabetes is such a global epidemic and a problem for all our healthcare systems and our people. And then finally, we've talked about ways to try and prevent type 2 diabetes. So again, we'll talk in the next couple lectures about what are all the medications that have been developed over the last 20 years, I would say, to try and treat and aid in these lifestyle changes for helping our patients. Okay? All right.